we will start within 2 minutes time. So just get on board. So within 2 minutes time, we'll start our CME. Good afternoon, everyone. I am Aschalo, the moderator of this CME on ethical communication. And I am an internist by profession and pulmonary and critical care medicine physician. This time I am a co-chair of the scientific committee of Ethiopia Medical Association. And I would like to say on behalf of Ima and myself, welcome to this CME session. And today's CME session is part of the pre-conference session of the 59th annual conference of IMA. And the topic for today's CME is ethical communication. And in general, as you know, CMEs are for two purposes. One is to update members of IMA on current medical practice and ethical issues. And second one is to accumulate CPD points. And this CME has got a CPD CEU point of 1.5. And to earn that, you need to attend the whole session, and there will be exam question by the end of the session, and that will be dropped on the chat box. And you need to score 50%. That is the cutoff score to get the certification. And certification will be given within 2 weeks' time after this session. So the mode of our interaction will be some lecture will be given by the presenter. Then if you have any question or comment, you can put it on the chat box. And then by the end of the presentation, we'll have a response from the presenter on the issues. And in the meantime, you will work on the exam positions. Can you hear me, please? Getting it? Am I audible?
Yes.
Okay, thank you. So then you'll do that one and we'll summarize it. So today's topic is selected because of its importance. As we have seen in the regulatory part of medical ethics, we have seen that most of the reasons for liability for the physicians are due to miscommunication with their clients or with colleagues and with the responsible bodies. So based on that finding, we have planned to have this as the first CME topic for presentation. And this presentation will be made by Dr. David Desalegn, who is currently a department member of obstetrics and gynecology at Addis Ababa University College of Health Science. He is also a coordinator of the medical ethics collaborative project between the University of Bergen and Addis Ababa University College of Health Science since 2011. And he is also the head of the Center for Medical Ethics and Priority Setting in the same university. He's a medical doctor by background training, and later on he went to specialty training in obstetrics and gynecology, and then he has done his fellowship program in gynecologic oncology that was run by Addis Ababa University in collaboration with University of Michigan and Emory University. And he has assumed different positions in the school, as a department, and in professional societies like Ethiopian Society of Obstetrics and Gynecology, where he served as EC member and also project coordinator of the Violence Against Women project. He is also a member of European Society of Gynecology and Obstetrics, and he was also a member of Ethiopian Medical Association, and he is currently a fellowship director of Obstetrics and Gynecologic Department, and he's pursuing his PhD on medical ethics and priority setting at the University of Bergen. And he has served as an associate dean at Addis Ababa University College of Health Science, School of Medicine. His clinical and research interests involve varieties of women's health issues, such as gender, ethics, and priority setting, and gynecologic cancer. He has several publications on the above mentioned interest areas, and I hope he's the right candidate to present this topic, as he is currently a clinician practicing, a researcher, and a PhD candidate on ethics. So now over to you, Dr. Dart.
Thank you, Dr. Aschalo. Thank you so much for the introduction, and welcome all participants. I hope my voice is audible well, and if not, please just let me know.
You are audible. Please proceed.
All right. So the topic as introduced today will be on ethical communication, and I would like to declare that I have no conflict of interest making this presentation. And the objectives of today's lecture would be for the participant to acquire brief understanding on medical ethics, and they will be able to discuss what are the themes of medical ethics at the end of the lecture, and to be able to acquire ethical communication skills and understand some tips on communication as medical care providers. So these tips we will discuss on 4 good habits, and another tips for communication challenge and when conveying bad news to the patient. So we'll try to go through these objectives, and then we'll try to see whether or not we have achieved this at the end. So are we all okay with these objectives?
Yes, Dr. Dart.
So medical ethics, it's a philosophical discipline, and tries to determine what is morally right and wrong related to human action. And you can understand ethics by simply being the right conduct, and bioethics is the right conduct relating to human biology. And when we discuss ethics, there are 4 major areas. One is research ethics. The other is ethics of genetics, and the third one is ethics of public health, and the fourth is clinical medical ethics. So when we discuss about ethical communication, so we tend to deal mainly on clinical medical ethics. Okay, so that is the part. So when you understand bioethics, you need to understand that we have these 4 different divisions of bioethics. And the themes of clinical ethics include the following: the doctor-patient relationship, communication, respect for patients, end-of-life decisions or end-of-life care, reproductive health ethics, and priority setting. And the focus for today's session will be on the above 3. Okay, what we mean by doctor-patient relationship, communications, and respect for patients. So we will not deal with the other part of clinical ethics today because it's not the scope, but I'll try to touch upon these 3 areas. And since the last 5 or 6 decades, there has been big drivers of change in medical ethics and how we as care providers think. And this is mainly because of explosions of new medical technologies and procedures. and there are growing social concerns and related to human rights, and the moral obligation of care providers to the patient or even to the society. And currently, we in the world globally is facing with complex medical decision, particularly on priority setting. What care should be provided and what can we forego. And during this decision making, the communication with individuals, the communication with the society becomes a challenge. So the goals in general, the goal of clinical ethics is to improve quality of patient care. And this quality can be achieved by identifying, analyzing, and attempting to resolve these problems that can arise during the practice of medical ethics. And this communication and how we communicate is the key in achieving this goal. So we'll try to see how these communication gaps can create problems, and then how we can also change these challenges. So the ethical dilemmas that can happen during our clinical encounters or activities can include, when you have limited resources like ventilator and you have to make a decision who should get it. And what if a woman raises the recommended cesarean for fetal distress, and how would you go about and how do you communicate with such encounters? And when somebody discloses HIV status for a discordant couple, then how do we communicate with the spouse or even the patient? And then which intervention is cost effective? Should we prioritize maternal health or child health, or is it cardiovascular, or is it mental health? And these complex decisions needs evidence, but that needs to be conveyed in the right way. That means communications are quite important to convince society, to convince patient that one is done against the other for different reasons. And this has to be conveyed clearly with patients. So when we discuss about before we jump into the communication skills, then we need to understand the basic ethical principles, which the global community has agreed to be abide by these 4 principles that should be adhered to during the practice of medicine. And one is the autonomy. We need to protect patient autonomy and protect the vulnerable. And we need to always do good and avoid harm. And then the fourth one is justice. So these are the 4 major principles that we abide with. And then we shall see each one of them, how our ethical communication can impact on the practice of these principles. Do you have any questions until now? So I assume that there is none, so I will move on. So remember these themes, then the focus for today would be the relationship, the doctor-patient relationship, communication, and respect for patients. And medical ethical communication is quite essential in all areas of life. As you know, you need to communicate, you need to be a good communicator in all aspects of life, but it becomes quite crucial in the field of medicine because you are always dealing with humans and their emotions and different levels of understanding of the same problem. So that needs to be well communicated. So this ethical communication is quite essential. And it's quite important to build trust and to maintain effective relationship with your clients. And because patients also rely on you to provide them with quality care. And the goal, as we said, of this ethical communication or ethics is to provide quality care. And this ethical communication has critical role in meeting this expectation of the patient in trying to get optimal care. So when we assess these 4 major principles and then how we communicate, then the first principle is the principles of autonomy. So how does these principles act with the communication? When we say respect for autonomy, individuals have to have the right to make decisions about their healthcare, but that decision-making has to be reasonable and available. Otherwise, it's not the right to respect whatever the patient wishes. So you don't need to misunderstand the concept of autonomy, because this impacts also on your communication. It's not the autonomy to, or it's not the right for the patient to make decision on unavailable and unreasonable choices. So that means it requires the care providers to respect the patient's right to make informed decisions, but at the same time, the patients have the right to refuse treatment. But this has to be reasonable, and these choices have to be available. So our role is to provide with complete and accurate information and treatment options, and of course, the benefits and risk of each intervention. For instance, the patient with advanced cancer may choose to forgo chemotherapy and focuses on palliative care. And what will be our role, and how do we communicate this potential need to go against the recommendation in favor of another care? But how do we really communicate? So when we respect patient autonomy, it means it has to be respect for their rights to make the decision, and our role is to provide the right information, and we need to be ready to accept their refusal for the availed information. We'll come to how we actually communicate during such discussions, but now the aim is to understand those globally agreed upon principles, 4 principles, which is autonomy, doing good, avoiding harm, and providing equal opportunity for all, which is justice. So these 4 agreed upon principles, what will be the communications, or what is the ethical communication for this 4 agreed upon principles? And the next one is doing good, because we should always act in the best interest of our patients, and it requires us that actions that promote patients' well-being and improve outcomes. And it involves providing effective treatment and preventing harm. And when we try to provide good, there's always a chance that we can harm the patient. Okay, so the most important thing is to provide the net benefit. So any medication that you provide can have a side effects. Any procedure that you do can have undesirable effects, but the most important thing is to outweigh the risks and benefits. So in these cases, when the patient are cared for, that we need to consider their values and preferences when making the treatment decisions. So different patients can have different values and understanding for the similar recommendation. Okay, some patients, for instance, if you can recommend the surgery for chronic pain, but some of them may prefer to try non-invasive treatments, and then this could be discussed in a way that you are all aligned together on the treatment plan. And avoiding of harm is also quite important, and in this case, it involves avoiding harmful treatments, minimizing the risk of adverse events. And the 4th one is justice, which requires us to provide equal care for all patients, regardless of their backgrounds, race, ethnicity, age, gender, and so on, or religious background. So you need to provide equal opportunities for equal care. So you need to avoid any biases or prejudice, and this communication becomes quite important. And you need to have any biases or prejudgments on the patient. For instance, your patients could be drug addict, but you don't need to prejudge while you communicate, and then you need to continue to provide equal opportunity for all. And the other one, which is related to respect, is confidentiality. And how do we communicate, when we are trying to avail patients' delicate data or information to others. So maintaining patient privacy and confidentiality is quite important, and their information has to be shared only to the authorized individuals. Okay, but the medical communication is not just prescribing the right treatment, but good medical care is more than that. And it also requires a strong patient-doctor relationship. This relationship has to be built on trust, empathy, and mutual respect. So just think about your day-to-day activities, and then how how this can impact, on your daily care. So these three important things are quite important to remember: trust, and your empathy, and mutual respect. You have to respect your clients, and then they have to respect you back. But respect is earned, and how do we earn that respect? The importance of this relationship is quite evident in different evidences, and there are many publications on this. And when you have built good trust, and when you have good doctor-patient relationship, patients are more likely to follow. They are more likely to follow, your treatment plans, and they are more likely also to adhere to medical regimens and share important information about their health. And it leads to a better outcome, and there is increased patient satisfaction. So this has been evidenced through many publications that a good relationship can lead to better patient outcomes and patient satisfaction. And to have this in place, effective communication is important. And then for effective patient-doctor relationship, you need to establish trust. You need to communicate effectively. You need to respect their autonomy, and you need to stay honest and transparent along the care. How do we establish trust? One is to become trustful, and if for the patient to rely on whatever recommendations you provide, then you need to be quite competent. So updating yourself, now part of the CPD is, updating yourself would add to the trust that you gonna build with your clients. So the patient needs to feel that you are competent, honest, and respectful. And it's good to take extra time during consultation. I know it comes easy to say than do, because you can have maybe 20, 30 patients waiting only in the morning, and you may not have time to provide the required, attention. But still, what you can do is try your level best, to give them time so that you can listen. So you need to provide them with clear explanation of their diagnosis and then treatment plans. And you need to communicate these plans effectively, and you need to use plain language, and then try to avoid medical jargons. You shouldn't say, for instance, myocardial infarction. They will not understand it. Okay, heart attack would suffice. So in all aspects of your fields, then you need to try to provide simpler languages that they can understand. And you need to listen carefully and respond to their inquiries with empathy and compassion. The other is respecting. We have already discussed this. So you need to support the patient in making these informed decisions, and you need to align the support with their values and principles. Different people have different values based on religious or social backgrounds. And then you need to respect, those values. It's not just because treatments are made available, but that has to be aligned with somebody's values and preferences. And it is required that you stay honest and transparent, and we will come to it when you have bad conversation or difficult conversation, and how do you stay honest and how do you stay transparent. So patients have the right to know about their illness, but you need to stay honest on their conditions, treatment options, and potential outcomes. You should avoid to give false reassurances, to patients while you know the potential outcomes. And similarly, also vice versa, you don't need to you don't need to give them unnecessary, loss of hope on the outcome. Now, communication and decision-making is quite important. So we need to foster this autonomy or respect for patients through respect, trust, and quality. And that the goal of patient care is a shared decision-making. So it's not only you that is making a decision on one's care, but the patient has the right to decide with you. Even though they are not professionals in the medical field, it's their body that they're going to provide, for you to intervene. And then they have more rights than we have in making those decisions. So all our duties will be to provide the right information with the right communication. So shared decision-making, SDM, is a journey aiming at fostering patient autonomy, curating help of you who will be or who are attentive to patients' informal, emotional, and rational needs. So it's not only a physical need, but this shared decision-making would require you to be attentive to the informal, or emotional and relational needs that the patients have. So this is just a graph to show you when first time the patient comes to you, their autonomous capacity is very high when they are healthy. And, so when this health becomes deteriorated for any disease, there could be symptoms, there could be perceived uncertainty, and they'll become vulnerable. And then this is where they will seek your help. So by the time they come to you, their autonomous capacity is quite low. Okay, it's quite low. And then it's up to us to build or to empower them, to build trust, and to be competent on scientific uncertainties so that we know what to recommend. And we need to feel responsible, for the patient. And with all this intervention, we can bring back the invaded, autonomous capacity to the normal level. So this is the goal of shared decision-making, is to empower them again, because disease process by itself or illness can invade their autonomous capacity, and they will rely on whatever you recommend. And you don't need to abuse that power, but in fact, you need to use that opportunity to empower your patients. Right, so this can be built on shared decision-making by involving and giving time and showing empathetic or sympathetic, communication. So this is the goal of the shared decision-making. So there are certain tips that we use whenever we encounter with patients, and I have chosen, there are many, but this is what I have chosen based on my previous experiences, these 4 good habits. I hope some of you are well aware. So this requires for you to invest in the beginning of the consultation. And then the second one is explore patient's perspective and show empathy and invest at the end. If you use these 4 principles to communicate whenever you have individual or group encounters in medical field, then you can achieve good communications. Okay, so try to exercise these possibilities. What do we mean by investing at the beginning? Simply, to use our own language, it will bring about trust. Okay, and you're showing respect. It shouldn't be that you are the knowledgeable and the big guy, waiting for somebody vulnerable, to welcome. But you should be the one welcoming, your clients, and by having a good respect based on cultural values. Okay, so if you have to get up from your chair so that the society believes that is a sign of respect, then do that. So that is what we mean by investing at the beginning. It's not only the communication, it's not verbal, but the non-verbal ones counts quite heavily. So you need to understand what the patient wants, and then you need to plan the consultation, telling what you will be doing. So don't assume that they know. When they come to you, they are quite vulnerable and they don't know what to expect. So please try to understand their perspective in a way, and try to provide. And the first encounter, the first impression is quite important. If they feel that you are there to help them, then you build this rapport, and then that is quite essential for the continuum of care. And then you need to explore their perspective. That means, what does the patient know and expect? And based on my experience, people come, they may be referred, and they don't know whether they are having a life-threatening problem or it's just a simple problem. Unless you really ask and try to understand their perspective, they are not mostly aware. So you need to make sure that you are aligned together. So you and your client's understanding becomes the same. So this can also, their problem can have also an impact on their daily life. Now, if this person is coming to you with a hand injury, and this guy is like a pianist, and relies on his hands or her hands to make a living, then you can imagine the impact in their livelihood, okay, in their well-being in general, societal well-being. So you need to really understand the perspective of the patient. So then you can have very good communication. And the third one is you need to show empathy, and you need to be open to patients' emotions, and show empathetic behavior, like also the nonverbal one. And even just touching their shoulders, can mean something. And sometimes I have seen some physicians crying with the patient, but that should be avoided. It's not professional to show your reaction to or your emotions to your patients. And you can imagine if you are crying with the patient, then they lose hope totally. So your communication needs to be professional, and that makes it also ethical when you are professional enough. And lastly, I know the empathy, Albert Einstein said, it's potentially, patiently and sincerely seeing the world through the other person's side. It's not learned in school, but it's cultivated over a lifetime. So we don't expect one to develop this empathy overnight, but this is something that you continue to develop, but you need to work on it. You need to continually work on it to have this developed. And then, unfortunately, most of us don't usually conclude our consultations. We just leave them suspended and open. And this is not quite good. So at the end of your consultation, this communication should you need to end and check out on unacceptably. So you have to say, then I will do this, and we will do this, we will be monitoring this, and so on, So clear end to your consultation has to be given. So these 4 good habits involve investing at the beginning, understanding the patient perspective, and then showing empathy along the way, and then you need to conclude based on whatever discussion you've had. So going forward, what are the difficult conversations that we can have during clinical encounters? Sometimes it is telling bad news. So how do you tell the person has an STI? How do you tell a person that they have cancer? And how can you tell them that they no longer be able to walk and so on? What about conveying, or having conversation after making a mistake? What about when the patient is not prioritized? As I said, you have one ventilator and you have prioritized one patient and then left the other. So how do you tell the other patient that has not been provided with the resources or their family members? Okay, when the patient is angry and trying to accuse you, how do you communicate, And some patients could be rational, and then sometimes also the patient, and it's very difficult to communicate because of your biases, because the patient. So these are circumstances where you can have or where you can face these difficulties, and how do you go about making, the communication? So there are certain tips. So we will use 2 tips, and one of them is the mnemonic nurse. This is for communication challenge, and each one of them, we'll go through it fast. But the first one is naming, the emotions. How do you respond and accepting patient emotions? So you need to name the patient emotion. Then the example would be, it sounds like you're worried that the cancer is back. So you need to state it clearly what they have. Okay, so if you feel that their emotion is like worried about whether a disease is coming, whether they will be disabled for life or and so on, you need to clearly name the problem. Okay, this is one tip that you can use. So remember, please, to use the tips nurse. Okay, so literally you are nursing their emotions. Okay, so it sounds like you are worried that the cancer is back. And the other one is understanding. You clarify on understanding of a patient concern. Then typical communication would be, my understanding is that you worry about how your wife will respond. You're probably managing a case who just been diagnosed with an STI. Then you have to understand, their concerns. How are you going to communicate? How are they going to communicate with their spouses that they have an STI, and so on? So this is also one thing to clarify. So when you tell them that you are trying to understand their worries and their emotions, then they will come to you. They will work with you. And then you need to give them, respect. not only nonverbal, but also verbally. You need to tell them that it impresses you how they have been able to take care of their families or themselves, during these difficult times of disease and so on. So you need to continue to show respect. And then you need to support them and tell them that you will be there throughout the illness, no matter what. You will be around to be with them, throughout the illness. So this guide will help you communicate effectively with your client, and then trying to understand their emotions and responding to them. And the last one is exploring any concerns that the patient may have. And you need to ask them at the end, can you tell me about your worries about the treatment? And so you need to understand the options that you gave them. Is it acceptable by them? Is there any worries, and so on? So using this acronym, mnemonic nurse, then you can try to respond and accept patient emotions. And the other is when you tell them, bad news. There are cases where you need to convey that the patient has certain weeks or months to live, where they have a new diagnosed cancer, or they will not be able to walk, and so on. So these are quite difficult times, and then this bad news has to be told. And then there is also a mnemonic that we use, and then this is spikes, and these are the 6 items that we use for such communication. Okay, S stands for setting up for the interview. So you need to ensure privacy, because this is a bad news, and then you need to make sure that you have adequate time. Just don't do it while you are on a rush. When you are telling a person that they have a cancer or they have this life-threatening problem, don't tell them while you are rushing, and so on. You need to make sure that the timing and so on is appropriate. And the other is perception of his problem. Do they really know, what they have? So you need to assess their understanding and perception of the problem. And then you need to invite. It's not always, when we say being honest and transparent, it doesn't mean that you have to tell everything to the patient, or the other way around. But you need to invite them, whether or not they are willing to be fully informed or not. Okay, there are, during the process, you can tell them that you have identified, based on your investigation, a certain disease entity, but you need to ask them first how much they are willing to know, because some, patients prefer not to know details of, their prognosis. So, but this invitation is in a way to make them comfortable and for you to understand what level of information they want to get. So you don't just dump or dodge all information you have on them, but you can gauge it based on this discussion, okay, based on this invitation. And you need to have the knowledge and information to the patient. That is, you need to give them just small amounts at every time, and avoid medical jargon, as we said previously. And then you need to cross-check whether they have understood what you've been saying to them. It's not only at one go, but you need to cross-check once and then time again whether or not they have understood. And their emotions should be explored and acknowledged, and you need to empathize and explore their expressed emotions. Okay, and at the end, you need to summarize and plan for future care and treatment. This is even the good 4 habits. You have seen that we need to conclude with clear summary. So this is, you can say at the end, I will do this, and we will reevaluate, and we will come back again, and then reassess this test and so on. So you need to have a clear plan so that they are with you along the care. They are with you along the care. So as a summary, medical ethics tries to determine what's morally right and wrong related to human action. And the themes of medical ethics include ethical communication, which is respect for autonomy, patient-doctor relationship, and communication. The other is end-of-life care, reproductive health ethics, and priority setting. And today we've discussed only the first 3 on communications. And the goal of this endeavor is to have quality of patient care. And please remember the 4 ethical principles, which are the autonomy, respect for autonomy, doing good, avoiding harm, and provide care for all. That is justice. Okay, equal care for equal people. And ethical communication would be quite crucial for establishing positive relationship, and effective communication involves respect for autonomy, acting in the best interest of the patients and avoiding harm, providing equal care to all patients, and then maintaining patient privacy and confidentiality. These are the 4 principles that we have discussed. And shared decision making is a goal in any communication or any clinical care. And these 4 good habits can help you along the way. And the mnemonic that we use, the nurse, for understanding and accepting patient emotion, and the spikes for conveying bad news, are quite helpful tips. And we need to always treat others how we would like to be treated, with respect, trustworthy, and providing quality care. Okay. And by following these principles, physicians can ensure that their patients feel heard, valued, and supported throughout their medical journey. And I thank you all for listening. And now I can open the floor for discussions. Thank you.
Okay. Thank you, Dr. David, for this clear and focused presentation. So there are some questions in the chat box. I will summarize that for you. But till we do that, dear participants, I have put the link for your multiple choice questions. And in the meantime, you can respond to these questions, and that will be a 50% requirement is there to get the certificate. So you can check the link in the chat box. In the meantime, Dr. David there are some questions put in the chat box. One is advantage and disadvantage for the patient when patient refuses useful intervention. Who can take the risk? This was raised by Gavello. So if the patient refuses an intervention that saves his life, then is that appropriate to respect his autonomy is a question, and who is going to take the risk if the outcome is bad because of the patient decision? This is number one. The second is, Amin asked about to have more explanation on the 4 good habits of communication. And the third question is, do you think these principles can be customized to our society, where most of our patients are illiterate and expect the doctor to make the decision on behalf of them? So is there any possibility to modify these things to the societal status of our community is the question. If more questions are put on the chat box, I will come to you, and then we'll take more questions. So you can respond to these questions, Dr. David.
Okay. Thank you, participants, and Dr. Aschalo. So the first one, if I may respond, is the advantage and disadvantage when patients refuse useful intervention, right? So yes, it's one of the dilemmas that we face on daily practice. Now, as I said, if one refuses recommended cesarean, right? What are the things to follow? So, respecting patient autonomy, it implies that you should not give care which is not available and which is unreasonable. So the patient needs to have a clear capacity to make informed decision, and that has to be judged correctly. And some patients may not have a clear capacity, and that has to be professionally assessed. But there are, and for instance, now if we talk about cesarean section, which is in my area, then certain countries have rules. Now a mother in certain states can have the say to say, no, I will not have the surgery. But in certain countries like Norway, for instance, then the mother is forced to have the cesarean section. So it's not up to the mother, but the state decides, because the baby is a citizen and has the right and will be protected. So it all depends on the legality of the country. But these are the advantage and disadvantages, So whenever you use law to judge the ethics, then harms and the advantages can come. Both can come. So it all depends on the society and how you see the things. So of course there are advantage and disadvantage for each. And the second question, if I have answered it correctly, fine. But if you need more explanation, please put it in the chat box so that Dr. Aschal, you can see and then let me know. And then the other one is the explanation, the 4 good habits. This is just trying to have this same principle in while having conversation with your clients, with your patients. So invest at the beginning. That means you just greet the patient, tell your name, show respect, So the first encounter is quite important. And then try to understand their perspective. Are they really aware of what's going on? Try to understand their perspective. How does this impact their livelihood? How does this disease impact their livelihood? So you need to really understand that perspective. But we tend to, as clinicians, we tend to focus only on the disease and avoid, the impact of this disease on the daily life of that patient. So you need to understand the perspective. And then while we do this consultation, you need to always continue to provide the sympathy, and you need to be empathetic along the way, trying to put your shoe in their shoe. Right, so their emotions needs to be respected, and then you need to provide time and respect. And lastly, most important thing is that you need to make a conclusion of that consultation. You don't need to make it suspenseful. You need to end the consultation with a conclusion. So today you've come here for this, we did this, and then this is what we're going to do. And then I will give you an appointment for next week to do this. So you need to conclude with strong suggestions and a clearer plan. That's what we mean by good habits. So this is a good, acceptable, ethical communication. This is a very good habit to adhere to. And the third one is customizing the principles to our society. Yes, that needs to be done. For instance, from the 4 principles that I have conveyed, autonomy tends to be quite interesting, in different societies. In our society, it's not only the patient that decides on himself or herself, but it's also the families, the society, the elderly, the religious leaders, all are involved. So autonomy is quite tricky and it's a bit difficult. But the principle, the concept behind autonomy needs to be respected. And then, of course, the autonomy also entails that the patient has the right to involve others in the decision making, all right? So this is part of the definition. So it's not only that you protecting the right of the patient to decide on herself or himself, but it is also the right to choose from available and reasonable choices. And it's also the right for the patient to decide to have others involved in the decision making other than the physicians. Okay, so that's how we need to customize it. But the other 3 principles, particularly doing good, avoiding harm, and justice, it doesn't really require, customizing, because this works throughout. You avoid harm and you do good, which is the principle, and then to try to provide equal care for on available resources. You need to equitably share, and this is particularly important using distributive justice. Okay, when you have limited resource and then you have plenty of demand, then you have to make difficult choices. So this has to be made, in a way. And then there are different calculators, but it's not the scope of today's discussion. But there are many different ways of trying to prioritize. That is one of the topics, of medical ethics or clinical ethics, which is priority setting. Dr. Aschalo, if there are more questions, please let me know.
Yes,
and if
thank
this
you,
is not
Dr.
clear,
David, for the explanation. And there are some more questions. One is, please comment on how these ethical principles are affected by the setting of practice, like, for example, private versus government. This is one question. Then there are 2 questions which are similar. I will link them together. And it says, how do you see the practical medical ethics in Ethiopia and the drawback of Ethiopian physicians in communication, and how to deal on it is the questions. So this is the second question. The third one is, if the patient refuses useful treatment, and if they persist while we are pursuing them, do we need to ask their mental health status because the refusal for useful treatment is because of not understanding or respecting autonomy, rather because of they are not healthy mentally is the question. So do we need to go for checkup for mental health status is the other question. Another one is how do you define authorized, for example, in terms of confidentiality, if somebody is lost from follow-up, and if the person has, for example, a communicable disease like tuberculosis and so on, how do you see the confidentiality status? Do we need to disclose, to search that person for his potentially infectious to the community? And by the same token, for other is the question. And I don't know, there are multiple questions, but let me continue and you can respond. How do we assess patients' readiness to accept bad or good news? That's another.
Good or bad? What?
News. If you are going to disclose bad or good news to the patient, and how do you assess their readiness to accept that news, be it bad or good, is the question. The other is, how can we have empowered ethical committee in Ethiopia is the question. This is very interesting, I think.
What? Empowered?
How can we have empowered ethical committees in the country? I think the clinical ethical committees, let me put it that way, is the regulatory one. So that is how can you have that one is the question. And we'll proceed with other questions and they can respond to this one.
Okay, quite a lot of questions, but now principles are principles. እንግዲህ ሰማይ ቢወርድ የሚባል አለ አይደል? Principles, whether you practice in private or government, it has to be the same because it is ethics, it's not law, you know, and it's about moral questions and it's up to individuals, you know, whether you're practicing in private or in government, then the principles are the same. And I can understand the question behind, you know, the idea behind this question. And sometimes you can see some unnecessary or immoral or unethical, you know, practices in certain areas. And yeah, that has to be condemned. I cannot say that ethics principles can change based on your setting. They are all the same. It's not only in the setting of private practice. This is globally accepted principles. Okay. And the practical medical ethics in Ethiopia, I don't know if I can really understand that question, but let me probably do the others and then I'll come back to the second one. The other is useful intervention refusal. Yes, informed consent by itself requires certain things, and one of them is privacy. You need to ensure privacy, you know, confidentiality, and then the capacity of the person to consent. Okay, so if you are providing an option for an intervention and the patient refuses, you need to, in the background, always try to assess their ability, okay, to consent, or their capacity to consent. So yes, you have the professional duty to assess that. So if you feel for any reason, now a patient comes with head injury, okay, head trauma, and then refusing surgery on burr hole, then this assessment has to consider that their capacity to comprehend can be somehow affected by the disease process. If somebody is septic and having, you know, different decisions, then you have to you know, understand as a group, as a, you know, group of clinicians, or even as an individual, that their capacity to consent or their capacity to understand could be somehow affected by the disease process or by underlying mental health issue. So this is up to you to assess, but it's not always the case that you need to assess this and then send them to psychiatrists for evaluation and so on, but you need to make this delicate decision based on your own assessment. But if in doubt, yes, it's advised that you seek professional's advice, okay, on the capacity to consent, okay, when they usually refuse a recommended intervention. And confidentiality and loss to follow-up infectious illnesses, yes, yeah, I think in most societies, it is agreed that when somebody is a threat to another person or to a society, then this confidentiality can be breached. But you know, you need to, as much as possible, try to provide as confidential information as, to the limited or authorized individuals. Okay, but yes, there are certain circumstances that can force you to forego this principles of confidentiality when there is a threat beyond the patient. Okay, and assessing readiness of the patient, whether they are ready to accept good or bad news. This is individualized. There is no, I'm not a psychiatrist, and I cannot really tell that the one can clearly tell the difference, but at least the patient has the right to know. And as we said on the tips, you need to understand their emotions and then try to assess how much they are willing to know on the disease process. Tell them how much they want to know. So then you can judge to yourself how much you can tell, and you may withhold. So it shouldn't be that you tell them everything at one go, but you can gradually, convey the message in succession. In succession. It's not that you have to dodge everything at one on the patient, or this could be quite damaging. So yes, it's not, I don't know if I wish I was, or psychiatrists were around to tell me that, but I don't know. But I know how to communicate. And when I communicate, I try to use those steps. Okay, when you are conveying, use the steps of spikes. And then you can use those guides to guide you through conveying bad news to the patients. And then lastly, how can we have clinical ethics committee? Then we call it CEC, Clinical Ethics Committee, and we have just established one, and we've been working on this and Black Line, at College of Health Science, and then we have now a committee that has been established, and this is a committee that can help and guide when clinicians when they face with such ethical dilemma. So yes, and the plan is to have these committees in each of the major hospitals at the beginning, at least, so that, clinicians are guided through these difficulties in communication, difficulties in conversations, and so on, when the ethical dilemmas that I have briefly touched upon earlier can be managed accordingly by this committee, which can be a good support to clinicians. And Dr. Aschalo, if you can come back to me on the second question. I did not really understand the practical medical ethics. I did not catch that. If you can get back to me.
Yeah, I think my understanding to the question is, in terms of communication and ethical practice in this country, how do you see the current practice of medicine by doctors in Ethiopia? I think in relation to ethics and ethical communications, that is the way I understood it, and the drawbacks in the communication of physicians to their clients or among themselves, and any suggestion how to deal about is a question. I think to just they want to have clarification about ethical practice in the country.
Okay, so yes, yeah, now I think I get it. And then we have conducted some studies amongst our clinicians, and we have assessed different areas of clinical ethics. One is their readiness on this topic. Did they go through medical education on medical ethics, and how much dedication was there in their school years? And then was there any trainings, such trainings, in service trainings, and then whether or not they believe that they should be included and or not, and so on. So what I can tell you is the trend. The trend is that most of our clinicians, before maybe 10 years ago, did not have enough background courses, on medical ethics during medical years. And then when they were asked whether or not they should be included, most of them agreed that it should be included. And then the practical aspect of it and practice could be assessed in certain ways. And unfortunately, most of our physicians, more than 80%, would avoid their profession because of financial reasons, because of the burden they see on their patients. So it's quite burdensome for them to continue to practice this profession, because the poverty level on the patients and not being able to provide the required, treatment plans was judged to be a reason for them to not like, their professions. But this papers are also available online, and you can refer to them. So we have many publications on the area, and you will be surprised on how our physicians react. But practically, this needs to be improved. It's not only in our country, but the ethical communication and the ethical practice and so on has to be improved. And then we need to convey this data, this reality based on data. I cannot just say that I think, this is wrong, this is right. Based on the studies we've conducted, there is a good willingness to learn. There is a good willingness to go through these ethical principles and, practice them. But the actuality is patient. Our clinicians are not well trained in the area, because you need specific training, and these are skills. Communications are skills. Knowing the principles are trainings that you need to be provided. Unfortunately enough, now most of our medical universities have started, teaching medical ethics, and it is now even now AMI is giving it due attention, for the last many years, and many universities have good capacity, in a way, compared to the previous year. So I believe that this has changed positively, although we are not yet where we are, but where we want to be, but at least there is a good start.
Okay, thank you, Dr. David. I think we need to go to the last questions, and then we'll summarize it. It's very interesting, and I think questions will never end. And there are a lot of attendants too. So other questions are, whose responsibility is to break bad news? Is the question. Who should break bad news? I think this is a serious practical problem. Is it the one who is there during the time, or is the treating physician, or the one who has the highest level of expertise on the field? This is a common question that is asked when we give ethics training. So who should break bad news is one question. The other is related to the families. If a competent patient asks the physician to make the decision after consulting his families, how do we need to decide? How do we go about where the client is there, and if the client delegates his families to make decision on behalf of him is a question. And if there is a difference among family members, if they decide in the decision making differently, how do we go further is a question. The other already have answered it. The question was about the pre-service training, and you have responded it for that one. Another question is about research ethics. I think the one who asked this should attend the next. We have another 4 series of CME, and one of is about research ethics. So you can raise the research ethics. Here we are talking about the clinical ethics, and particularly about communication ethics. So I think you'll get that answer from there. So the 2 questions are there. Who is going to break bad news, and if the family is delegated, and if there is a difference among themselves, how we are going to act is the question, Dr. David.
Okay, yeah, very good questions. And yes, I think as a practice, and the general practice and globally accepted, is the primary treating physician has the responsibility to convey the bad news or any news related to care and diagnosis. But this can change based on the relationship built during the care. Now, in certain times, nurses are quite closer to the patients than physicians in most scenarios. And then that building trust, if physician is not competent and is not honest and respectful and so on, then whatever the physician conveys may not be respected and may not be seen as a good thing, in a way. So the patient might prefer for some clinical healthcare provider that they have built trust on. But the obligation is for the primary treating physician to convey the right news or the wrong news. But depending upon the relationship build, because medical care is not individual care, it's a team's work. And then in that team, whoever believes that they have built a good relationship should be the one to convey. So there are no rules, but if nobody is willing to tell, then the primary physician has the obligation to convey the message. So as I said, for the second one on autonomy, if somebody delegates the autonomy to the others, yes, as I said, the definition of autonomy is to the right to make decisions, but those decisions has to be available and those decisions has to be reasonable. Okay, and the right also involves the right to involve others to have the decision-making power. So a person can delegate someone, and then if the families don't agree, then no, there are hierarchies. Okay, so the family, if let's say that somebody is comatose, and then the next, according to our law or any law, is the spouse that comes if the person is married. Okay, and then after the spouse is the, if they have children, then the first child can come. And then if not, then the parents. Okay, so there are hierarchies on what we define as next of kin. So if the families don't agree, it doesn't matter. The person can only delegate one in making decisions, but they shouldn't argue on this. They can convey, but one person is delegated to make the decisions if it is willingly given to them. But by law, if the person is not able to make decisions, then there are, hierarchies in the law that you ask for them. So even it can, sometimes it can trickle down to physicians. Huh? You will be the one to make the decision at the end when things are not, in the favor of the patient. I think this is the case, and the research ethics, as I said, I think you can discuss this in the next session.
Yes, thank you. And I think I don't see any more questions on the chat box, and all questions were responded accordingly. And I think to summarize all the discussion, ethical communication is part of the competency of a good practicing competent physician, and we need to be very competent in our listening skill, in our speaking skill, and expressing ourselves to our clients. And it should be very trustful, respectful, clear, and compassionate. That is very important. And our ability to communicate also has a great impact on the outcome of the clinical care to our patients, because if we build a trust, well communicated, they will trust us, adhere to our recommendations, treatment, and follow up, and our advices for personal lifestyle changes. So that's very important. But if our communication is very poor, it may end into confusion, conflict, failure to address suffering, rather it will worsen it, and sometimes it may end up into error and harm also. So we need to have an honest, open, clear, and respectful communications. That is very important. So we need to, there are things that from a physician side, we say that there are a lot of barriers, like patient behavior, level of education, socioeconomic status, time shortage, cultural diversity, and so on. But we need to be, as a patient advocate, we need to be aware and candid on these issues and be able to address, rather than undermining or discriminating patients based on these gaps. So it's our responsibility to have these skills to communicate well with our patient. In terms of time and good communication, effective communication, the first time, it seems that it will take some time, but don't forget, well-communicated patient will revisit per our schedule. Otherwise, if you fail to communicate, the thing is clinical condition will worsen, and it will not have trust, so we'll come again and again in between, and the cumulative time we'll spend with our patient will be too much higher than the one with whom we have effective communication at the beginning. So at the end, it will save time. At the beginning, it seems that it will cost some more time. So be careful, and good to practice communicate effectively at the beginning. There are different models, as it has been said by Dr. David, the 4 habits, the 9 C's, and so on. But the most important to all of them is that you need to have a good word, tone, and body language. This is very important. All our voice, words, and body language should pass the same message. If there is a difference, it should be confusing, and the mixed one should be very concise, very clear, consistent. When we speak to our patients at different times, we need to be very consistent. And always we need to address our audience, their status when we communicate, because our wording also matters. And the content should be very relevant. We need to pass very informative message to our client. And we need to, not only we are expected to talk, but we need to make sure that our clients understood what we have talked. So that is very important also, checking for understanding, choose the right medium based on the problem. So, and use a common language. So this is very important. And always don't forget, when you talk about empathy, it is about putting ourselves in the shoe of the client. But to stand on the shoe of the client, we need to stand properly in our shoe also. So always when care for our clients compassionately, don't forget that we need to be compassionate for our service also. Self-compassion is very important, because one with fatigue will have poor communication and poor outcome to the clinical care of the patient. So self-compassion is very important. One who is very mindful physician is the one who can communicate well with his clients also. So having said this, I would like to thank Dr. David, his very excellent presentation, very focused one, and his explanation to the questions that you raised. And I also thank you for your attendance, because we have got almost around 240 attendants in the middle of the session. This is very important thing, and I'm happy for that and for your interaction also. And I invite you to attend the other CMEs, and also the 59th annual conference to be held next week, EMAS annual conference. That is my message from my side. And if there is message from EMA Secretariat, GetNet, that's for you from my side. Thank you and have a nice weekend. GetNet, over to you if you have any message to pass.
Okay. Thank you, Dr. David and Dr. Aschalo, for your very good presentation and the moderation of this first CME. We will have another 4 CMEs, and our participants can attend the next CMEs. The next will be by tomorrow, and then after on Monday and Tuesday, we'll have, by tomorrow we do have 2, on the Monday another one, and then on the Tuesday the last CME will be presented. We will give 1.5 CU for each, and the certificate will be prepared within the next 2 weeks. And I want to ask our participants for your patience, because we have to collect all the data. Then after we will prepare and then send it to your email using the information or the email you provide us. Thank you very much for your attendance and for your presentation all. On behalf of IMA, I would like to say all of you thank you. See you again. And those who registered for annual conference, would love to see you on March 17th to 18th. Thank you very much. Thank you, Dr. Aschalo. Thank you, Dr. David.
Thank
all
you.
the presenters.
Thank you, everyone.
Thank you. Thank you, everyone.
Thank you. Ciao.
Thank you.
You did what you had to do, right?